This episode, I'm joined by Dr. Kathleen Kendall-Tackett. Dr. Kendall-Tackett is a health psychologist and an IBCLC lactation consultant, and the CEO of Praeclarus Press, a small press specialising in women's health. Dr. Kendall-Tackett is editor-in-chief of the journal Psychological Trauma and was the founding editor-in-chief of Clinical Lactation. Dr. Kendall-Tackett specialises in women's health research, including breastfeeding, depression, trauma, and health psychology. She has authored more than 490 articles or chapters and is author or editor of 41 books. Her most recent books including Breastfeeding Doesn't Need to Suck from 2022 and Women's Mental Health Across the Lifespan from 2017. Her 41st book, Depression in New Mothers, 4th edition, is in press at the moment. Dr. Kendall-Tackett discusses with us not only a vast range of topics specific to her work and new book, but also some big and confronting topics in this episode. A warning before we get going, Dr. Kendall-Tackett discusses early on in the podcast about her research and work with women who have experienced sexual assault. In this episode, we delve into postnatal anxiety and guilt, the power of oxytocin and a mother's spidey sense, and the vulnerability during the early days. We look at sleep, mental health and breastfeeding, postpartum depression, and we even tackle placental encapsulation and its potential effects on milk supply. We look at secondary trauma in midwives and doulas, as well as birth partners, burnout in midwives, and look at shift-based versus continuity of carer model. And we look at how adverse childhood experiences affects adult health, and how women who have experienced sexual abuse prefer to engage with breastfeeding, and what the research is showing. I really hope you get a huge amount out of this episode. It is jam-packed. So pop the toast in the toaster, maybe take the dog out for a walk, or maybe put the keys in the ignition and get going, because you're in for a treat. I'm Katie James, and this is the Midwives Cauldron podcast. Each episode, I'm joined by my incredible co-host, Dr. Rachel Reed. Listen in as we hubble, bubble, toil and trouble our way through aspects of womanhood, midwifery, birth and lactation. So go on, subscribe now, and hear us on your favourite podcast host. Welcome, Dr. Kendall-Tackett, to The Cauldron. It is an absolute bloomin' pleasure to have you with me, and my colleague and co-host, Dr. Rachel Reed, is very jealous that she's snoozing soundly in her bed.
I was going to say it's probably the middle of the night there, isn't it?
It is about 3 a.m. for her right now.
Yeah.
So that would have been pushing it to get her up for Brisbane/Texas time.
Yeah, definitely.
But it is a real honor and a treat to have you on. And I said to you earlier, I have been a big fan of your work and come and visited you or come to conferences to hear you speak and been inspired in my sort of career as a lactation consultant for 16, 17 years now. And you have this way of talking to health practitioners and also to new mums, new parents, just this way that really resonates, helps us to think about things and also really implement that into our practice. And I love that. So
I appreciate that. Thank you very much.
It can be really tough, like trying to keep up to date with everything. And then you get, 11-page research paper and you think, oh, Lordy.
Well, yeah, because I don't see how somebody who's full-time clinician could possibly do that, and the research changes so much. That's the thing.
Yeah, it's constant. And you basically spend your day just reading research if you want to kind of keep up to date. And that, thank goodness for conferences. That's for sure.
Right.
And podcasts. I'm going to just plug us now. Podcasts like this, where we can get people like you to come on. I'd like to start with just asking you to tell our audience a little bit about yourself and how you got into the field of health psychology and lactation consultancy, because we don't often put those two together.
Well, it was a little bit of a circuitous journey. I actually had my PhD in developmental psychology.
Mm-hmm.
So that was actually where I kind of thought I was going to stay. And then after the birth of my first child, kind of all of a sudden sort of crashed into the field of perinatal psychology. And just part of it was, just trying to kind of understand my own experiences. And I thought, well, I just out of school. I just got out of school. And it was like the thing I thought, well, the way to do it is to actually do what I've been trained to do, which is read the research. And as I was reading it, I'm thinking the stuff that they're saying at conferences and everything I was hearing, all supposed experts. I was living in the Boston area at the time, which was the epicenter of the postpartum depression world. And they were just all talking about it was estrogen and progesterone, and we need to get women to wean, and we put them on this cocktail of medications. And I mean, it was just, and I thought, I am not seeing that in the research literature. It's not there. And I thought, and then I asked, I had, some of the people I had conversations with, I said, well, what about things like, childhood sexual abuse? That doesn't matter. It makes no difference. Seriously. And partner violence, same thing. Just any kind of family violence was not considered relevant.
Wow.
Wow. And it's like I did my postdoc at the Family Violence Research Lab at the University of New Hampshire, and I went to study with one of my idols, Finkelhor, who's really considered one of the experts in the world on childhood sexual abuse, and was studying with him. And that was actually, I did my dissertation on child sexual abuse. And I actually honestly couldn't believe people were not considering that when they were thinking about a mental health issue. It just was kind of shocking to me. So yeah, that's how I ended up. Actually, I got a book. I bought myself a book called How to Write a Book Proposal. And I said, with book in hand,
guide.
wrote a book proposal and sent it off. That was actually the first book, because I thought, I don't believe this, and in fact, I interviewed a bunch of women. I put an ad in the Depression After Delivery newsletter, and I got, through the post, letters coming back and saying that they would be interviewed. And so I interviewed them, and a lot of them actually came back and were talking to me about, how their experience of what they were sure that this was all hormonal, but then they tell me about some horrific birth experience, or something, that was not, one woman was talking about how, she suddenly realized that she was a sexual abuse survivor right there in that, first time she held her baby. It was like all this stuff came crashing back. And yet people started talking about estrogen and progesterone, and it was kind of like, wow. And so, yeah, I wrote about birth trauma in that book, even though we didn't really have a framework for it. But it was, I was reading one of the first books that was put together on post-traumatic stress disorder, and I thought, this fits. And so kind of like tried to line it up and, tried to line up what I was hearing from what mothers were telling me. Yeah. And so that's kind of how I started doing it. And so then eventually, I kind of realized for me, developmental psychology seemed like it was not as relevant anymore. And I kind of drifted a little bit. And then I found health psychology, which really fit in with my family violence work, because it was a framework for helping me understand why, like childhood abuse affected adult health. And so, for me, that health psychology framework was actually extremely helpful. Then what happened, you asked kind of how I got into lactation. I started off by being a Lactation League leader. And actually still am, kind of on the inactive role, but, I've been for like 25 years now. And I actually used to do that breastfeeding stuff as my happy little counterpart to this stuff I did. And then, Lactation League started asking me if I would speak on depression. And then they asked me to speak on child sexual abuse and breastfeeding. And I said, no. I said,
really?
They said, why not? I said, because there's no research on it. What would I say? I'd be standing there doing sock puppets. But then I heard what other people were saying. And I remember telling my boss, I said, I got to get into this. So I thought, well, probably the safest way is to take what we do know, because there was a big literature on child sexual abuse, but none of it was touching the perinatal health field. And I thought I can take and show what we know, and then I can apply it to how I think that would fit with a breastfeeding mother. And so that's what I ended up doing. But yeah, literally when I first started lecturing on it, there was nothing. There was absolutely nothing in the field on it. And there was such a need for it. But I was sort of, bumbling around. And then the mothers actually were the ones who came up and were talking to me at conference, just telling me about their experiences. And one of the things I realized is that anytime you think you make a hard and fast rule on something, somebody's going to come along with it as an exception, so it's kind of like I've learned not to make big predictions. But the thing that really made me get into it is, and this was just horrifying to me, I was at a conference and there were a couple of midwives talking, and they were saying that if you suspect somebody, has a history of sexual abuse, you need to confront them on it and say, I know you have a history of this. I thought, whoa, that's absolutely the wrong approach.
Yeah, yeah.
I was appalled by that, actually. I thought, no, you know what? You don't actually have a right to this information. Practitioners have actually no right to this information. And actually, it's something I said in the book. I said, look, you can tell people if you want. I said, but you don't have to. You can put a boundary there if you want. It's really okay. And what I've told practitioners for years is like, if you see, okay, this and this, just in your head, no, this may be a trauma survivor. We don't know exactly what, and you don't need to know exactly what, but then you can behave as if, and so, and honestly, I think, some of the things that are just good practice, ask before you touch, explain what you're doing. I mean, things like that.
Should be practice for everybody, regardless.
I think so. It's funny because somebody told me, they came up to me after conference and they said that they'd taken an education program, and they said that the instructor said to them that you shouldn't actually ask permission to touch a woman's breast because it communicates that it's not normal. And I said, it's not normal.
To just randomly touch someone's breast.
Yes, you're going to get arrested. You don't walk up to somebody and say, "Oh, nice to meet you."
Yeah,
it's like,
let me just come in there.
So I mean, I think some of that is honestly just good practice and giving women control over how undressed they are. Whether they're, it's like, I think unfortunately some of these, instruction things that we have where women are completely topless, I think that in some ways sends a wrong message that you have to be topless in order to breastfeed your baby. And for particularly people who have a trauma background, that's going to be really hard. But I think actually that's hard for a lot of people. I think that may put them off versus if you can show them, look, you can do this very discreetly.
Oh God, absolutely. Yeah, I couldn't agree with you more on that. We do have some issues with our imagery, so. Even that. And how we talk about it. And just, I mean, a huge amount of what we talk about on the podcast is this kind of this language we use and the consent issue that is not happening, or implied consent before anyone's actually said yes. And then
right. And I'll be the first to say, I know, we know it's not good practice necessarily to touch, but sometimes honestly it's easier. But you always,
of course,
get the mom's permission.
Yep. Totally. And we've all been in those situations, but it is about permission and waiting for that answer, and also trying to judge the situation, which is something that it takes time as a clinician to learn. And also, looking at those good mentors that work with you, and learning from them.
Right. Exactly. And one of the things I said is it's not necessarily all the credentials and everything and all the letters after the name that makes a good clinician. I said, some of the best ones that I've ever known have been people who've been like long-term, like league leaders and stuff, who are just good. They're just good with people, and they just have a nice way, and they kind of can figure out problems and things like that. And so, and even if somebody's a good clinician, they may not be a good clinician for you, because it's kind of to do with, the mesh of your personality. And
yeah, God, that's such a good point, because we talk about this in terms of going to therapy or seeing a psychologist and how it doesn't always fit. But I think as birth workers or as support people in the birth sphere, it can feel really awful if someone doesn't get on with you. I mean, obviously, this is a tricky, complex subject, but I mean, I would feel like, God, what have I done wrong? But
it could be, personalities don't quite mesh.
Yeah. And we don't get on with everybody.
Right.
I haven't actually introduced that. I mean, obviously, everyone's heard our introduction, but you have written such a great title, and I just want to mention it again, of your new book, which is Breastfeeding Doesn't Need to Suck, How to Nurture Your Baby and Your Mental Health. I just love it. It's a beautiful title.
I have to say, my editor came up with that title, but I thought it actually kind of expressed the sentiment, because that's the thing I hear so much from mothers, is how miserable their experience was. And I thought, why? And it kind of comes back to like what Jack Newman has said in his new book. He said, basically, everybody who comes in contact with a mom should know two things: how to assess the latch and how to determine that the baby is drinking from the breast.
Yes.
He says, there's so many things that could be averted if everybody knew that. But
Yeah.
how many times do they send mothers home who actually have never had a successful breastfeed,
Yeah.
but the baby's kind of been there, or the mother's saying, I'm really sore. And people are just like, oh, it'll get better.
It's
It's like,
normal. Don't worry about
it's
it.
not normal.
Yeah.
It's common, but it's not normal. There's a big difference. Yeah.
I love that. It's common, but it's not normal. And I was like, that resonates with me. I feel like I'm reading words I've said. Totally. It is these basic things that often they make the biggest difference. And then what's happening is we're then sending women home who
Right.
feel like, okay, well, this is normal. I have to then keep going. One of the biggest reasons that they give up is not enough milk, whether perceived or real, and sore nipples. And
Yep.
and when Jack Newman talks about those two factors that we should be all skilled in as midwives,
Right.
as OBGYN nurses, as home support, doulas,
Mhm.
anyone working with a mother and infant dyad, they're the
If they knew
basics.
those two things. Yeah.
Yeah. And when we
They
miss them, it leads down this path of
Mhm.
what you've described in the book, what the research is looking at, which is often this kind of postnatal anxiety, this
Right.
doubt, this kind of guilt.
Well, this idea too that like if this is natural and I
Mm,
don't know how to do it, what does that say about me as a mother? It's like, you know, it doesn't actually say anything about you as a mother. It means you probably weren't exposed to it.
yeah.
It's like it's natural. There are definitely some things that support you in this, but you can suppress those, like with bad advice. People give you bad advice. And also too, it's like there has to be you have to be in the right situation for those things to start kicking in. So I actually try to kind of say, look, it's natural in that there definitely are these things, but it's also learned.
Yeah.
Kind of take some of that pressure off. It's like, okay, and if it's learned, that means you can learn it. Because you can plant that negative little seed of doubt there, even unintentionally. It's like this is something I've kind of learned. I've been working with Dr. Kirsten Ibn-Smoberg, who's
Yes.
the big
I'm
researcher.
very jealous that you've got to work with her as well.
Oh yeah, no, she's we have actually had such a kind of a fruitful collaboration because I come in from the stress and trauma section. She comes at it from the oxytocin, and they're really kind of two sides of the same coin. It's kind of like when one oxytocin can suppress all that.
Yeah.
Flip that stress response, but it can go the other way around. The stress response can actually suppress oxytocin, so if that becomes the thing, if the mother becomes very afraid or if she's in pain, I mean, what's that going to do? It's going to suppress all that, and
Yeah.
it's going to suppress the natural protection. But yeah, one of the things that she has taught me is that during that time when mother's oxytocin is really, really high, one of the things that helps you do is tune into social cues, which is really great for learning to read your baby's cues, but it also makes you very vulnerable to even hints of negativity.
Yeah.
It's like you get spidey senses. And so it's kind of like if somebody comes in, like, so let's say, they couldn't find a bright spot or they're pissed off at their husband and they come in with that energy into the space, the mom may think that it's about her.
Yeah.
Or if you say something even just like remotely negative, that can actually have a very long lasting effect. But it goes the other way too. If you're positive, if you plant positive seeds there, that can also go, so it's just kind of like to be aware that mothers are so vulnerable during that time.
It's a difficult space to be in as a birth
Yeah.
worker sometimes, and a difficult place to tread.
Well, it is. It is. And kind of recognizing, that there's a vulnerability, but also, like then you can kind of not take it personally,
Yes.
to recognizing that this is kind of an abnormal situation, it's an unusual situation, but that, if sometimes you feel like a mother is taking offense to something you say, it's probably more due to her oxytocic state than that you've said something terribly wrong. I mean, you can, say, oh, I'm sorry about that. How can I help you with this?
Mm.
As somebody who kind of puts her foot in her mouth on a pretty regular basis, I
Yeah.
can actually say sometimes an apology goes a long way. That's the thing, you kind of learn by bumping around and making mistakes, unfortunately. I just did a paper over the summer with Cheryl Beck, and we looked at, particularly secondary trauma and moral injury in birth providers,
Mm-hmm.
from having observed, really traumatic births.
Yep.
And especially like nurses and doulas, I think, are in that position because they're not the primary providers. They're not the ones in charge, basically. And so a lot of times they're vulnerable to the actions of other people.
This vicarious kind of trauma that they
Exactly.
take on because they weren't in a position of being able to change the scenario or do the
Right.
support work that they wanted to support. And then this also brings us to how fathers can often, or partners can often
Right.
feel in that
Absolutely.
space of, I wasn't able to save her, or I wasn't able
Right.
to change the situation, or I couldn't prevent such and such happening. But yeah, as
Right.
birth workers, we can absolutely feel like that when we've maybe been the midwife caring or the doula caring for this woman for a
Mhm.
long period of time, particularly with those strong relationships where we
Right.
have got to know someone early on in their pregnancy and followed them all the way through. If we're lucky
Yeah.
enough to work in that model of care.
It can be very, very hard. And it's funny because it's like the situation you're describing with the shift or the patient-based, midwives, the ones that actually see the patients all the way through,
Mm.
versus shift-based, tended to actually have lower rates of burnout overall. But there's also a vulnerability there too, because you have a relationship with this woman. If something bad happens to her, then it just feels harder. It's like, I think the shift idea was trying to, let people kind of have a life, so that you could actually plan, you could go on vacation or you could go to a birthday party or something like that. But it
That's also
seemed
good.
to, yes, it was good. So I think the idea was to prevent burnout. But the unfortunate thing is actually, and this was an actually study after study after study, and there was even a big review article that was published, I think, in 2020. And it was like 24 articles or something like that. And they all showed the same thing, that the shift base leads to higher burnout, which I think is actually really interesting. But it kind of goes back to that relationship. And that's actually one of the things that, in an article in one of the midwifery journals was kind of pondering, is this idea that, does the relationship with the woman protect the provider or make them more vulnerable? And they actually kind of came back and said, well, it can be both.
Yeah.
Yeah. But yeah,
And
that kind of relationship makes a difference.
yeah, we need more. We definitely need more of looking at this kind of field. We talked to Ellie Young recently, and she was just talking about the God, what's the word? Now I'm going to have to think about it. I won't put this in with me thinking hat. I probably will. She was talking about how our somatic experiences of how we walk in and whatever we are feeling, we sort of exchange in the energies that are going on, and how this can be perceived by the woman and how we can pick up on that. We take it with
Right.
us, we bring it back into that. And regardless of whether we're sort of standing there or sitting in the corner and knitting, if you're allowed to get away with that without straying eyes going, you're doing nothing,
Right.
of how this influences, regardless, you're in the room and your presence and your energy right there and then that's being exchanged. And this fascinates me thinking about this in
Well,
everything we
it's
do.
kind of an interesting thing. It makes me think of the studies that were done in Sweden. And I've I've always been fascinated with this because they did, kind of education. It was for midwives and public health nurses, the ones that kind of did the home visitation and
Yeah.
follow up. But what they did is they did, a randomized trial where they compared regular lactation training, just the education type stuff that we normally do, versus kind of a process oriented, which is like you basically had a chance to talk about your own experiences and kind of process them. So maybe you have a great experience. So maybe you have a chance to kind of like get rid of that basically and get rid of your junk. Well, anyway, so then, they randomly assigned these midwives to who had no idea, which group that their midwife was in. But the midwives who were in the process oriented training actually, had better breastfeeding experiences, were more likely to be exclusively breastfeeding. They judged all the other practitioners more positively. It had this huge like halo effect. And so it's kind of like the mothers didn't know. And yet there were these huge differences between the ones that had the process oriented versus the standard training. But didn't have a chance to kind of bring in and have a chance to kind of process your own experience. And that actually made this huge difference in like the exclusive breastfeeding rates. And I mean, it's just amazing.
Yeah, it
Actually,
really is
that
amazing. It's
isn't
such a
that?
simple technique to use and give space and time for that. They come with their own experiences, and there can be a
Exactly.
huge amount of trauma and upset that has been there for
Right.
years. And
Yeah.
then I'm there saying, this is the latest studies on X, Y, and Z.
Right.
And then you can kind of see the body language of going, or people come up to me afterwards or in the break and say,
Yeah.
I wasn't able to breastfeed. Now I feel really terrible. And so I learned over the years that I need to kind of do an icebreaker to say, we're going to go through X, Y, and Z, but give that space to kind of have that debrief, because how many of us have had, like, you're actually helping the woman with her new baby, and then the grandma comes in and says, oh, I wish I'd had this support when I had the baby. And you know, 30 years later, she's still holding on to, God, they came in and they did this and they grabbed my breast and then I really hated it. And
yeah, it's amazing actually how often that comes up. And it comes, I mean, even, you know, moms who are contemporary. I mean, it's like, I can't believe how much, you know, because just when they find out what I do, they come up and, you know, start talking to me about this. And it's like, actually, that's kind of how the Breastfeeding Doesn't Need to actually came to be. I was actually, I had just been elected on a board for the American Psych Association. And so I decided to go ahead and say, you know, about what my other career is. And so I, you know, introduced myself as a health psychologist, and, you know, I edit the journal Psychological Trauma, and I'm also an international board certified lactation consultant, you know, and you could see like the men in the room rolling their eyes like, oh, please. Oh. But their chief acquisitions editor came up to me at lunch and she said, I'd like you to write a book for us. Because I'm thinking, okay, you know, what could I possibly say, you know, that hasn't been said in all these other books? But then I sat around at lunch and I listened to what these young women's experiences had been. And I thought, okay, I think I actually know, you know, what to talk about.
I want to quote you because I read something in your book that I really liked, and I want to bring this into our conversation. And you wrote, are women who breastfeed less likely to be depressed, or are depressed women less likely to breastfeed? And there seems to be this confusion that I have heard and still hear, and you talk about in the book, in terms of, is breastfeeding causing the depression and therefore we should tell this mother to stop breastfeeding? And the best thing is that she reduces the breastfeeding because it's putting stress on her and she's not getting enough sleep and blah, 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 blah. And we go down this route. And I hear this very much. And you talked about this really well. And I think it's still happening, unfortunately.
Yeah, I know. It is all the time. Okay, so people have kind of assumed that what I have said is that breastfeeding never get depressed. And that's simply not true. You know, it's simply not true, because so many of the mothers that I worked with early on were all depressed breastfeeding mothers. You know, I was getting tons and tons of phone calls, you know, for a while. And they were saying that they had called Lactation League and that, you know, they were going to reach out to me because they, you know, and I found out like 3 months after the fact. I couldn't figure out why I was getting all these calls all of a sudden. But anytime that somebody was calling the hotline for Lactation League International in the United States, they were getting my home telephone number if they said they were depressed.
Oh, wow. That's a bit much, giving out your personal telephone number.
You know, I mean, it was funny because the person who ran the hotline was a friend of mine, and she was lovely. She was just such a wonderful woman. But she said, you know, she told me about 3 months after the fact, because I'm sitting there and I'm thinking, wow, it's funny that I get all these phone calls. And she says, yeah. She said, I hope that's okay. I said,
bit late to ask.
I said, well, it better be, you know.
I've done it now.
So I've never ever said that, because it's like, that was, you know, all these women, it was the same story. It was awful. I mean, it was like they said, I've just been diagnosed with postpartum depression. I'm told I have to wean my baby, and this is the only thing that's working for me.
Yeah.
You know, and it's like, I thought, you know, we didn't even have even the most basic resources at the time, like to tell, is it safe to breastfeed while you're on antidepressants? We didn't have that. But I thought, I need to find answers for these mothers. You know, I just do. And that's kind of what, you know, so I've never, ever said that. So how do we like look at this, what is kind of like in some ways a paradox? Well, if you are depressed going into breastfeeding, you are actually probably less likely to either start or continue for very long without support. If you have support, the breastfeeding is actually going to lessen your depressive symptoms. We just had a really nice prospective study that showed that mothers who were depressed, you know, during pregnancy, you know, that by the time they got to 3 months, if they were exclusively breastfeeding, they had less depression. Okay. They were still depression, but it was lowered. Okay. But depression kind of makes you like not feel like you kind of cope with problems, and it just seems like it's a little overwhelming. So you are more likely to stop. And so what people have kind of said is that because breastfeeding women are more likely to stop, that they naturally will be more in the group of the non-breastfeeding mothers. And so they've already kind of congregated there. They've self-selected. And so then when you look at a study, you can't tell that breastfeeding is actually helping because they were already depressed. See what I'm saying? And this one person actually said that we were together speaking at a conference, and she was being very aggressive about it. But the thing is, now this person isn't a researcher, and she doesn't understand that the research design actually makes a difference. Okay, so if you do a design called a prospective study, which means that at time one, okay, so you're gonna assess mothers multiple times, but at time one, you determine that everybody in both groups is not depressed. And then you can actually look at feeding methods. So by time two, if the mothers in the bottle feeding group are more depressed than the ones who are exclusively breastfeeding, then you can actually say it was feeding method that made the difference, because there was a change from non-depressed to depressed in one group, but not in the other. Okay, now it doesn't mean that somebody in the exclusive breastfeeding group may not also get depressed. She may, but the overall rates are going to be lower. That's, so the percentage is going to be smaller. So that's how you tell, and so you can't really say that your average kind of one-shot survey, because there is going to be this sort of natural gravitation. But if mothers, and this seems to be true for exclusively breastfeeding, and I kind of in some ways wish it weren't true, because I don't ever want to make mothers feel bad for mixed feeding, because you do what you can do.
Absolutely.
Okay? But the actual biological protection seems to happen with exclusive. And it seems to be a down regulation of the stress system. And so that's what actually protects you from depression. And it seems to be a threshold effect. It doesn't, when I looked at the graphs originally, I thought it was, what you call a dose response effect, that the more breastfeeding that they did, the lower the depressive symptoms. That's not actually what our post hoc analysis told us. They said there was actually, in terms of depression, no difference in terms of mixed and formula feeding. So in other words, the mixed feeding mothers didn't seem to get the protection. And see, this is the unfortunate thing when people are trying to help mothers' depression and tell them to supplement. Yeah. You're probably going to make it worse. What you want to do is sort out the breastfeeding problems. Well, first of all, I think the first thing is find out what the mother wants to do. If she really wants to stop, then okay, we support that.
Yeah.
Okay. But if she wants to continue, and that's more the scenario that I run into, the mothers who want to continue and everybody else is telling her to stop, there seems to be something biological, physiological that kicks in that actually does act as a protectant. And part of it is because it helps with her sleep. All the markers that we look at that are things that are considered risk factors for sleep, like the number of minutes it takes to get to sleep, and then also to the total amount of sleep time that the mother self-reports. That's actually a better prediction than it is if you use like an objective measure like an actigraph or a polysomnograph. So the mother's self-report seems to be actually really important. But it seems to help with all those. It helps with the sleep. It helps with the mother's daily energy. Although I will say that the mothers are still tired. It's still postpartum.
Yeah.
But the question is, are they going to be more tired, if they start supplementing? The answer seems to be very clearly yes. There was a great study that was published in 2009, and it had, I think, about 1,800 mothers, 7 weeks postpartum, and it was published in a sleep medicine journal. And they were saying that, if you had sleep problems and, fatigue and stuff, it was a risk factor for depression. Having disturbed sleep is a risk factor for postpartum depression.
Mm-hmm.
But then they went through the list of things that they considered, the things that were contributing to poor sleep. And it was, first time mother, having a male infant, having a younger infant. So probably what we call late preterm infant, all those, we know male infants tend to be a little more sensitive, and they're at a little higher SIDS risk. They went through this whole list. And then the last one was not exclusively breastfeeding. In other words, the mothers who were not exclusively breastfeeding were having poorer sleep, which led to depression. So they were saying it was kind of using a double negative, but basically it's like if you were exclusively breastfeeding, it actually protected you. And that was in a sleep medicine journal. It wasn't, in some nice touchy-feely, attachment parenting, it was in a hardcore sleep medicine journal, and they found that. and we found it. And Jennifer Holbrook's found that. I mean, it's amazing how clear the pattern is.
It feels like such a paradox, though, when you're in that situation
Right.
of extreme sleep, when you're maybe down the path of mixed feeding and you're feeling depressed, and then you hear about the statistics of the exclusive breastfeeding supports you, but then you haven't been supported to make a full milk supply. And I mean, it's just this whole conundrum of lack of, for me, how I feel is just this kind of, we're missing these sort of windows of opportunity to really get things off to the right start, get things going, and making sure that there is milk that's going into the baby, that mums are not sore, and just, again, these basics. And then we've got women who end up with depression, who are mixed feeding, and then just feel completely like, well, I'm stuffed. And that's a really difficult position for us as practitioners.
Oh, it's horrible. I agree with you that that's a very hard position. And I think probably as a practitioner, I think the first step is kind of like, okay, talking to the mom, what do you want to do? How would you like to proceed with this? Because, if we can catch it early enough, we may be able to bring her back to exclusive breastfeeding. Yeah. But also too, the other thing is to look at, okay, does she have enough support that she can actually maybe take a little nap during the day? Does she have enough support that maybe, does she have the baby close to her at night, so she's not having to actually physically completely get out of bed, and get up and go, because maybe what she can do is, keep a little cooler with a bottle of some milk, next to her, and then actually feed the baby, without having to completely get out of bed. So there's some things we can kind of work around. And if she wants, you may be able to bring her back to exclusive breastfeeding, depending on how many weeks it's been. If it's been too many weeks, I think that's going to be hard. But I think the main thing is then making sure that she's kind of getting the rest and support. And, also to maybe even, if it's been too long, to maybe grieve and just say, you didn't get what you needed. And I'm really sorry about that. I'm really sorry that this happened. It's just horrible, and, sometimes it's just a situation where honestly, it may be too far, but I think actually one other thing I like to mention is, every once in a while you run into the mom who's like basically hanging on by a thread, that you just feel like you're going to die if you don't get some sleep.
Yeah.
And I think that one of the things that we can recommend in that situation is if she can actually aim for a 4-hour stretch of sleep. Okay, I think that's going to be a lot more doable, because people will tell you 6, but that's not really based on anything, and my recommendations are based on a couple of different studies that have looked at this with regard to breastfeeding mothers, and it was like the 4 seems to be kind of like the magic number, and so what I've actually even kind of recommended is that, in thinking about this as kind of an emergency situation, but you have to have somebody who's going to be awake during that time so you can actually sleep. Because if it's just everybody goes to bed, you're going to be the first one who hears that baby. So it's not going to quite work. So if you have somebody who's awake who can take care of the baby, then you can relax enough to go to sleep and to actually sleep for that 4 hours. So, even think about moving up that time, so maybe go 8 to midnight, so that way it's still doable for somebody who has to get up and then have the baby kind of near you for the rest of the night. But thinking about that, if you do that for a couple of days, it's really going to make a huge difference. You start getting a 4-hour stretch, you're going to feel kind of like the next day, like you're born again. I mean, it's just dramatic of a difference. So so sometimes think about that as kind of an emergency, because I think we always want to be very sensitive to the mothers who are, what I call more tired. It's like you have fatigue, the more tired. And it's especially those mothers that are just hanging on by a thread, and you can just see it in their face. They just, I remember actually when I was, training to be a LLC leader, and, we, at that point, we weren't really allowed to talk. And anyway, I remember seeing this mom, and I remember actually being kind of worried about her. I was working on the first book, and so I was kind of like paying attention to a lot of stuff and also interviewing moms and stuff. And it's like, I remember thinking, wow, okay, she has some kind of risk factors going here. Anyway, she came to a meeting when she was about, I don't know, 4 or 5 weeks postpartum, and she looked like she'd been through the ringer. She came into the meeting and she said, "Is this baby ever going to sleep?" She said it like that.
Ooh.
And one of the moms chimed in and everything. She says, "Oh no, he's 3 and he's still not sleeping through the night." probably true. Obviously, this mother was coping with it because she was pretty chipper about it.
Yeah.
But I think in that moment, that was probably not what this mother needed to hear.
No.
Just looking ahead, thinking about this is going to be my life for the next 3 years.
Yeah.
Yeah.
And where the space she was at right then and there.
Yeah. So I actually did jump in then because it was like, yeah. Yeah. Somebody said, I used that example one time and somebody thought I was being critical of Alicia. Like, I'm not. I'm just sometimes, moms say things that are true, but may not be the best for a mom who's maybe in more of a crisis.
Yeah.
Yeah. So I wasn't actually being critical. That's, what happens sometimes in mother to mother support groups. Dad, I think, was kind of, for me, probably that was one of the first examples I ever saw of that, but it was so vivid, to see how desperate she was, for sleep. And I thought, yeah, there is a distinction, so when I talk about like the nighttime breastfeeding, I always try to put in that kind of emergency strategy for what happens when you got a mom who's in that situation.
Yeah.
Because you do have to address that, I think. And, I think sometimes, a lot of times, the temptation is to say, oh, yeah, being tired is a normal part of postpartum. And I mean, and that is actually true. That's something I think a lot of times people kind of going back to things people misunderstand about this link between things like sleep and mental health and breastfeeding. They say, well, I breastfed and I was tired. Well, yeah, because it's like, our mothers were saying, our exclusively breastfeeding mothers were saying that, they rated their fatigue and their energy levels about a 3. Okay. Out of 5.
Yeah.
Okay. But the other mothers were like 2.5, 2.0, there was a big difference. It was statistically, huge difference actually.
Yeah. I think that's a really lovely, that 4 hours is such a good thing for us to concentrate on, because it can be overseen, and looking at those strategies for sleep, because sleep is so sort of entwined.
It is.
With how we're
like
coping.
Jim McKenna talks about, he says you can't separate, sleeping and feeding, for breastfeeding mothers. He actually coined that term,
sleeping.
And it's really true. It's kind of like you can't really make a judgment about what's going on with the mother's sleep unless you find out how she's feeding her baby. It's a really kind of critical piece of information. And that's the problem with the, one size fits all advice. First of all, I actually asked a question about that with our moms, and I think it was only like 11% said they had somebody that could handle the nighttime feeds. So wow. I'm not sure who these mythic people are who's going to take over these nighttime feeds. But, again, that would be another thing that probably mothers would feel badly about. Oh, I can't manage this. I can't do this. And, it's kind of like, okay, this is a tiring time. And if you're up trying to do all your household chores and you're entertaining people, and you're making dinner for people who came to see the baby, and
oh my God, yeah,
maybe we need to look at that.
Yeah,
it's like, don't let somebody in unless they've got a casserole in their hand.
Totally. Okay, I'm going to take us off course slightly, but it's within the topic of your book, and it's something that came up, and I thought, oh, dare I ask this? Because it might ruffle a few feathers. So I thought, yes, I'm definitely going to ask it.
Okay, let's go for it.
I want to ask you about placental encapsulation. Now, we have never touched on this.
This will definitely ruffle a few feathers.
Yeah, exactly. So that's why I thought I'm going to bring it up, because I was like, ooh, great. Kathy's talked about this in her book. I've read some stuff. For me, I've seen the ABM protocol in terms of galactagogues, and the placenta's containing pregnancy hormones. When we look at this in terms of we use the placenta to increase milk supply, it doesn't make sense in my brain. And now the ABM revised protocol, I think 2018, 2017, they also, do an assessment before we give a galactagogue. Yep, of course, absolutely. That should be number one with everything, do an assessment. But one of the factors they point out is also check if someone is taking placenta capsules. Yeah. And so then I saw it in your book, and I thought, I'm going to see what Kathy says.
I will say, there's definitely a ruffle feathers. Anytime I posted anything ever on my Facebook page, I get a lot of, oh, how could you do that? Yeah. So I'm going to actually just try to kind of concentrate on the science of this. Okay, so this has been kind of floating around my world for a long time, because remember, the original theory of postpartum depression was that it was due to the drop in estrogen and progesterone. So for a long time, this was sort of marketed as a way to replace those hormones so that you were less likely to get depressed.
Yeah.
Okay, now again, like I said, that estrogen progesterone thing didn't hold up. It's not in the research, and the best people can say is there's some people who might be sensitive to that drop. I mean, if this were kind of a universal response, everybody would respond to it, but they don't. First of all, you don't need to replace those hormones. But I thought, I knew people who were doing it, and I thought, it's if you believe that it's helping, it will actually probably help. Because people said I had postpartum depression the first time, and I did this, and I didn't have any depression. And it's like, great, and I don't want to take away your placebo, but that's pretty much what it is, because there's that estrogen progesterone doesn't do anything. When they actually have done randomized trials, blinded randomized trials, and it would be easy to test this, honestly. You could actually randomize people to get placenta versus steak in a capsule. And somebody said, well, it replaces iron. Okay. You could probably do that other ways, easier, much tastier. But then there's also the argument about the bacteria that some babies, like here, we have a CDC advisory saying not to do it because some babies have gotten infections, from placentas. Because placentas are actually as a filter. And okay, now in terms of milk supply, you are absolutely spot on, because it does contain those pregnancy hormones. And so what are they going to do? They're going to actually block the action of prolactin and oxytocin, particularly prolactin. They're just going to absolutely oppose it. It's like, you want to stop breastfeeding in its tracks, take estrogen. And sometimes even with the progesterone only capsules, people that get their milk supply go down. So that for me, like I kind of went from being, okay, if you want to do it, to no, I really actually don't think this is a good idea, and this is why. And if you took it and you got an abundant milk supply, honestly, it's probably because you were expecting to get abundant milk supplies. And I'm not saying that in a patronizing way. I'm saying that our minds are very, very powerful. And if you think something's going to help you, it probably will. And if you think something, you actually can have the nocebo effect. If you think something's not going to make any difference, you can take even really heavy duty, like chemotherapy drugs, like they used to treat like rheumatoid arthritis, and it won't help because your mind blocks it. So our minds are actually really, really, really powerful, and it's like that when they test antidepressants, they have to have a threshold above 30% that get better. And that's the placebo effect. You give people placebo, 30% of them actually get better. So it has to be higher than that to prove that the antidepressant works. And so again, like I said, if it worked, and you found that it worked, that's probably what explains it. But for most people, that estrogen is going to actually specifically block prolactin. There was a group out in Sonoma County, they actually put a website together about this that I thought was actually really interesting. And this one lactation consultant, she had taken very good case notes. And she started kind of noticing this pattern that there were a lot of mothers who had low milk supply that she couldn't explain. There was just no reason for it. And she went back through her case notes and noticed that every single one of them was doing placenta encapsulation. So she kind of went back and she actually wrote a little paper about that, just kind of explaining what her findings were. Now, it wasn't a study, but it was an observation. I mean, this is a lot of times how we start doing studies. We observe something clinically, and then we kind of do it. So, I mean, it does actually have value in terms of the fact that it is something that somebody has noticed a pattern, and physiologically it makes sense that it would do that. Because again, I double checked with Kirsten about that, and she said, yeah, definitely it retains, the estrogen and progesterone. And she said it would be, it would definitely block. So
that's interesting.
Yeah. So, I mean, people are free to do what they want, but, especially if you start seeing that it's impacting milk supply, I mean, that might be a thing to stop doing.
I'm really glad that I was able to talk to you on that topic and that it was there in the book.
I've learned, I mean, I said, this has been kind of floating around me for like 25 years.
But it's interesting to look at the research that is there.
But yeah, I'd say, that's probably one to skip. And it's like, if it's a matter of iron, honestly, there's iron supplements, there's also things you could do in your diet to eat, that will actually boost your iron pretty quickly.
May I ask you one more question before we go?
Absolutely.
You touched on it earlier, and it's something which can be a really tricky thing for us to discuss as practitioners, or to be even discussing with the clients in our care. But I think it's something that's really important. And you put this in your book as well, which I wasn't expecting. And then I was very pleasantly surprised that it was there. And it's talking about, as you mentioned earlier, ACE, adverse childhood experiences. And also in terms of women who've experienced sexual assault or abuse in their lives at some point, and how this interplays with breastfeeding. And I think this can be a really tricky area for us as practitioners to navigate and to know how to support a woman who has been through this, if she's disclosed this to us. Often there is a thought that all women will not want to breastfeed, or all women should be deterred from it, or all women should be expressing instead. And that isn't the case, is it?
No, definitely not. Actually, one resource, I'm going to grab it here. Hang on. There's this fantastic resource that I recommend everybody get. Let me get it off my shelf here. It's called Survivor Moms.
Right. They have a Survivor Moms Companion. Okay. We'll put that in the show notes.
Yeah, they've got one for pregnancy and one for postpartum, which is amazing. So this is actually written for the moms. They do trainings for the practitioners too. And so it's kind of like, I think really the main thing is, this is what I've learned over the years, is that first of all, find out what the mom wants to do. What are her goals? What are her dreams? How would she like to proceed? And also kind of be prepared that not everybody finds breastfeeding pleasant. I remember actually, I talked to a mom one time. She came up to me at a conference and she told me that actually in junior high, she had been raped by 3 classmates. And then she had to see these kids every day at school.
Oh my God.
She never told anybody. Not even her husband knew. I was literally the first person she knew that she told. And she told me, she said she breastfed 4 kids. She went to age 2 with all of them. Wow. And she said, she was a legislative leader. And she said, I'd never liked it. And I said, then I got to kind of ask you, why did you do it? And she said, it was important. And she said, I was determined to do it. So this is the thing, it's like not everybody's necessarily going to find this to be this really kind of positive, but it's an important goal for them. Yeah. And she said, it was important for me. And she said, I knew it was important for my babies and it was important for me. And she said, so I learned to cope with it. And she said, I never enjoyed it, but I learned to cope with it. And that was enough. Wow. I thought, that always has stuck with me. So again, finding out kind of the mom's goals about this, I think are really, really important. Now, some mothers actually report that it's just this incredibly healing experience. Other mothers find, oh my gosh, I can't do this. I just can't do this. Or I can't do this very much, like maybe nighttime is bad, so it's kind of like, what kinds of things are sort of triggering, and so maybe, and I've actually talked to moms who couldn't do it for a first baby, but then could for the second. So you're going to find just everybody's experience is different, and it really kind of depends on kind of what types of experiences they have. But, I just actually have a paper that's in press right now, and so hopefully it'll be out pretty soon. But I was talking about trauma and breastfeeding. And one of the things that I kind of really wanted to also point out is that for trauma survivors, particularly, there are, 2 really important kind of benefits for breastfeeding. I know we're not supposed to talk benefit language these days, but it's like really for trauma survivors, I think they're particularly important. One is that we know that breastfeeding lessens the intergenerational transmission of abuse, that breastfeeding mothers are much less likely to abuse or neglect their children. Okay. And that's a big study from Australia. With over 7,200 mother-infant pairs, they followed them for 15 years.
Gosh.
And it found that, breastfeeding for 4 months reduced the risk of neglect by 3.8 times, and the risk of physical abuse by 2.6 times.
Wow.
Yeah. Wow. So, pretty powerful study. Okay, so that's the first one, and we also know that the things that kind of tend to predict intergenerational transmission, sleep problems and infant temperament, that breastfeeding helps with both of those, but what we found, and I have to admit, in some ways, this was a kind of surprising, but in some ways not surprising finding, is when I looked at the impact of exclusive versus non-exclusive breastfeeding on sexual assault status, and in our sleep data, we had 994 women who said that they had actually experienced rape at some point in their life, so the most serious end of sexual abuse and assault.
Yeah.
And first of all, when I looked at the rate of exclusive breastfeeding for the assaulted versus the non-assaulted women, it was exactly the same. It was 78% for both. So that probably surprises a lot of people,
Yeah.
that it would be that high. So again, like I said, I think it's actually an important goal. And I think we don't do mothers a service by saying, oh, you don't have to worry about that. We try to discourage them, because find out, what is it that they want to do? But the other thing that was really, really cool is it actually lowered the trauma symptoms. It actually attenuated them. Now they still had, obviously an impact, okay, but it was lessened. Like the impact on things like minutes to get to sleep, total number of hours they slept. It was definitely lesser than the non-assaulted group, but it was actually even better than the non-assaulted women who were not exclusively breastfeeding. So it's like it's almost like it zeroes things out and gives mom a chance to make a fresh start.
Wow.
And think about the survival benefit of that, because I mean, bad things happen in this world, and it's almost like breastfeeding was built to actually accommodate that. I've had moms tell me that, the best sleep that they've ever gotten, that they've always been poor sleepers, because of their experiences. That the best sleep that they've gotten is when they were breastfeeding, because again, what is oxytocin doing? It is actually dialing down that hyperactive stress response that you get in trauma. So, I should have predicted this, but it was just like stunning to see it so clear. And the one that was actually the best was when I looked at anger and irritability, and the graph looked like this. Okay. So this was actually the exclusively breastfeeding mothers. The women who'd experienced sexual assault looked the same. It was like this nice straight line, versus there was this big spike up if you were not exclusively breastfeeding, anger and irritability. And that's exactly what happens in PTSD. Okay, you hear this with people whose, like, say, parents were in combat. There was actually on the National Center for PTSD, there's actually this guy who was talking about his dad, who was a veteran in World War II. Of course, undiagnosed PTSD, but he said he'd be totally disconnected, and then suddenly something would tip him off, he'd fly into a rage, because you get this very hyperactive stress system. And what exclusive breastfeeding did was actually make that much more chill. It just dialed it down. And can you see how that could actually affect, the risk of physical abuse?
Absolutely.
At the very least, because you're going to be less likely to lash out. It gives you the tools to cope with being the mother of an infant, which you desperately need. Everybody needs those.
Totally.
And so it's like there's, I think, special, provisions for trauma survivors within breastfeeding. A lot of times people don't think about it. They always frame it as, this is a way to feed a baby, and it's like this is product, you're giving human milk to your baby. And it's kind of like, it's this integrated system, between mother and baby, the physiology that flows back and forth, and there's as many benefits for the mother as there are for the baby. And it's not just about that you're delivering a product, that you're actually becoming a unit. And it's like that's affecting you too. And that's actually, I think, so important. And I think that's the thing people miss. I think I used an example. There was a speaker that was at a conference I was at recently, and she said, identified women that she considered high risk for not breastfeeding. And so her approach was, what can I do to have you give human milk to your baby? And I thought, wow, that kind of says it all. It had nothing about what, the mother needs or what the mother would possibly get. I mean, it was like nothing about her. It was just that she was a deliverer of a product. And I think that is so unfortunate.
And breastfeeding is classed as like, it's just food.
Right.
And it's so much more than just a food.
Exactly. And I think that's an important thing. Now, we have billboards in our town from our local, we have this organization called WIC, which is our supplemental feeding program for women, infants and children. And, they have a great peer counselor program. They've actually really managed to bring up breastfeeding rates among our lower income moms, which is fantastic. Okay. But they have billboards all around, and they're talking about every drop counts, and you're right. Every drop does count, but it's that one tiny fraction of this whole huge picture that we a lot of times forget, and I think that, when I was thinking about going back to thinking about what would I write in a book about breastfeeding, I thought this is what I want to write about, is that it is so much more than just feeding, and it's like, then you get these incredible long-term benefits, the lowered risk of heart disease and diabetes and metabolic syndrome. And I mean, that's going to be super relevant for trauma survivors. because they're at risk for all of those things, and the more ACEs that you experience, the higher your risk. Breastfeeding is going to level that playing field, and it's like that, I think, critical.
That's just brilliant. Everything you've said and the way you've talked about it and bringing the research in, and I have nothing else to ask you. Actually, I have a million things to ask you, but right now I'm not going to ask you anything else because we would be here for 12 podcasts. But I think we have covered some brilliant topics. I want to say a huge thank you. Is there anything you would like to leave, any golden nuggets before we sign off?
I would say thank you to all your listeners for the work that you do with mothers, I said, and families, because you make a huge difference. It's like if we can get things off to a good start at the beginning, it has long-reaching effects, that go far beyond, the perinatal period. It's like if we can help mothers establish that secure attachment to her baby, that's really that's the prize. That's the golden ring. It's like that builds a resilience in that child that even if they're under difficult circumstances, it's going to carry them through, so this is such critical work. If we can help the mom have a good breastfeeding experience, if we can involve the whole, the family in it, feel involved, we can get breastfeeding off to a good start, if we can help establish responsive care. I mean, these are all things that have huge long-term effects. And so I just want to say thank you for everything you're doing, and appreciate so much the work you're doing there on the front lines.
Lovely. Well, it's a great place to end. Thank you so, so much for joining.
Oh, you're very welcome. It was my pleasure.
Whilst I've still got you, because I know you're waiting for the bloopers, if you have enjoyed this episode, please keep sharing far and wide, and pop on over and give us a review on your podcast hosting platform. Lately, we have had the most scrumptious emails and DMs ever, and I bloomin' love them. But we still need your reviews on those podcast platforms. They're very picky. They like you to put it there. I know it takes a bit longer, but this really, really does help. There are 2 ways you can support the show coming in your ear holes: a monthly or one-off donation, and everything helps keep this show on the road, as they say. You can do this through the links in the show notes, which take you to our Patreon or Buy Me a Coffee websites. And lastly, before you go, my course, Breastfeeding and Lactation, The Fundamentals, has launched. And you are invited to go and check it out and what you could find inside. There's currently a New Year discount of 23% off until the end of January 2023. Righto, let's get to them bloopers then, and I'll see you next time. If at any point you say something and you think, oh, poo, I've said the wrong thing, just say, oh, poo, I've said the wrong thing. Oh, I've got church bells going. I don't know if you can hear them. Only the listeners with really good headphones, which is not mine, can hear the church bells. And they're going to be on this. They stay in.